Hello, my name is Dr. Kristen Higgins, and I'm a radiation oncologist at Winship Cancer Institute of Emory University, specializing in thoracic malignancies. So the role of radiation in oligometastatic non-small cell lung cancer is becoming increasingly more important and something that we're dealing with in the clinic for our patients more frequently than ever before. The question is, in patients that have limited disease burden, do they benefit from giving local therapy to their metastatic sites? And there is a signal that they may, and this is based off of two small trials in the United States that both showed a progression-free survival benefit in patients with oligometastatic disease that received SBRT following their systemic therapy. The caveats of those trials is that they didn't have overall survival endpoints, and they were also conducted before immunotherapy became standard of care in the treatment of stage 4 non-small cell lung cancer. But nonetheless, we did see an impressive improvement in progression-free survival if SBRT was used for oligometastatic disease, and that led to the development of a phase 3 trial that is now underway studying local therapy with either SBRT or surgery in patients with oligometastatic disease, and that trial is NRG-LU002. And in that trial, patients get their frontline systemic therapy. I should say that patients with EGFR mutations or ALK translocations are excluded. And after they get their first 4 cycles of systemic therapy, then they are restaged, and if they have 3 or less sites of metastatic disease, they would be eligible for this trial. And typically in this trial, what we're doing is radiating the primary in the chest. If there are lymph nodes involved, we give hypofractionated radiation, typically 45 gray and 15 fractions with a IMRT technique. And then any other sites of metastatic disease, whether it's an adrenal met, a liver metastasis, a bone metastasis, those are typically treated with SBRT, and there's a couple different dose fractionation regimens that can be used. Now, when I'm treating patients with oligometastatic disease off clinical trial, there's a couple different ways to approach these types of patients. Typically in our practice, we are using local therapy with SBRT for patients that have more of an oligoprogression type picture. So they get their frontline systemic therapy, and let's say everything is getting better, improving, shrinking on their scans, but then one new area in the lung or a site of original disease in the lung starts to progress. We typically would use SBRT for oligoprogression. And I think that's probably where we are using local therapies most commonly, in our clinic right now. I still do not treat patients routinely with SBRT for oligometastatic disease at the outset of diagnosis. I think it's very important to get systemic therapy first, and I think we're still trying to understand if we are seeing a survival benefit with local therapy for oligometastatic disease, and we don't have the answer yet. Right now, we just have the phase 2 data that shows a strong PFS benefit. So I'm not standardly doing that in patients off a clinical trial. I think right now we're most frequently using SBRT for oligoprogression. When treating oligometastatic non-small cell lung cancer, we typically are trying to use SBRT or SABR approaches. When we are looking at tumors in the lung, we tend to use fractionation regimens that we are using for our early stage medically inoperable non-small cell lung cancer patients, 10 gray times 5, 12 gray times 4, sometimes 18 gray times 3. Those are commonly used fractionation regimens. Now, if an area that we are treating with radiation is near a critical organ like the esophagus or the airway, my approach is to reduce the dose so as not to cause any high-grade toxicities in these stage 4 patients. So typically for an ultracentral tumor, I might look at giving between 35 to 50 gray, making sure that I'm not going over maximum constraints for the esophagus and central airways. In terms of dose fractionation for bone metastasis, there are multiple different regimens that you can use. We use 10 gray times 3, not infrequently. We're also using 16 gray times 1 for bone metastases, and then there's a real benefit to that approach because the patient only has to come in once to get their treatment, and I think that's important, especially right now in the COVID-19 era. For abdominal metastases, we tend to do between 3 to 5 fractions, anywhere from 45 to 50 gray. Occasionally, we may have to back the dose down a little bit more if there's a critical organ nearby, like the small bowel or the duodenum or what have you. But those are the typical radiation dose regimens that we're using. Now, in terms of the utility of radiation for oligometastatic disease for specific patient populations, for example, patients with EGFR mutations, that's an area of active investigation. There was a recent trial from China that was presented at the World Lung Cancer Conference in 2019, as well as ASCO 2020, that did show progression-free survival and overall survival benefit when treating patients with a TKI for 12 weeks and then coming in with targeted ablative radiation to the primary and other sites of metastatic disease. So there is some data that could be an approach used in patients with EGFR mutations also. We do not right now have a large phase 3 trial looking at oligometastatic SBRT for EGFR mutations, but there are some institutional specific studies, specifically at MD Anderson, I think that will add to the data for those specific patient populations.